Welcome to a Dr. K call. Today we're going to talk about anterior hips. I get a lot of questions about anterior hips, and it is the approach of going from the front. Actually, your hip is closest to the front of your leg and not your buttock. And so actually it is a very good approach. I used to do all my hips posteriorly. I have pretty much switched to 99% anterior. About the only time I do a posterior is if one of my previous patients really wants a posterior approach, or if they've had previous surgery requiring using the same approach. So I'm 99% anterior. I think the anterior in my hands is the best. There's literature now showing that your recovery is faster, and you actually do better initially, require less medication, and theoretically there's a lower chance of dislocation because of the way we are anatomically. We tend to sit with our hips flexed, and you haven't violated the posterior portion of the joint. It is an internervous, intermuscular approach, so it's between the muscles and between the nerves. And so any kind of surgery does some damage to muscles, but in this particular surgery, we're not dividing tendons, muscles, we're going between them. The newest thing that I've started doing is what's called bikini incision. And so the incisions that we've had trouble with an anterior are people that are obese or overweight, as their belly kind of hangs over the incision and they can get maceration and breakdown of their incision. So the bikini incision goes in the angle of what your bikini would be, and it is in the line of what we call Langer's lines, and so it is more cosmetic in terms of it heals better, and it has all the advantages of healing a lot better and looking a lot better long term, and it does not give you the typical perhaps more ugly scar. I use a subcuticular stitch, glue your skin together with a skin glue, so you have no staples, no stitches, and we're almost totally outpatient now. I'm probably 80 to 85% outpatient now, and most of my anterior hips go home an hour or two after surgery. I use a local long-acting anesthetic that really helps for the first 48 to 72 hours, and that's what allows us to do this, and allows you as a patient to go home and function at a relatively high level. I do have everybody use a walker for a minimum of 3 days because of that numbing medicine. You just can't trust your hip, or you can't trust your knee if we're doing a knee, because of the potential numbness and not having control. So anterior hips, I believe, are the way to go. If it was my hip, I would only have it done anteriorly. At this point in my career, after doing thousands and thousands of hips, I truly feel it's the best. It's a little more difficult perhaps from a surgeon standpoint. It takes some experience, and I think you're going to see more and more anterior hips in the future. So I hope this information is valuable for you, and have a great day. Thank you.